why you're here. And what my brief today is to give you a taste of what a clinical problem-solving lecture looks like at the RVC. And I'm going to be talking about a particular clinical problem that's quite common in dogs and how we approach that, and see how you go. So, as always, we're going to have a few warm-up questions. And for this, I'm going to ask you to draw on the screen. You all did that so well on Monday, so I'm sure you won't have a problem. So the first question I'm going to ask you is, if you were given £100 tomorrow, what would you spend it on? So make a mark on the, would you spend it on travel and a holiday, on a great night out, on shoes or a bag, sporting equipment, clothes, a horse? Excellent, excellent. And you know, the horse, or getting a horse, yeah, that would be good. So what's really clear from this is that travel or a holiday wins hands down. And you know, it doesn't matter what audience I ask this question of, whether I ask it of students, whether I ask it of vets, if I ask it of vet nurses, everybody says they would invest in a holiday. So we're all in the same boat. Right, so next question. I'm going to clear that now. I wish I was lying on a beach at the movies, walking my dog, playing with my cat, riding my horse, at home with my parents, shopping, reading a book right here. Excellent. Great. Okay, and that's a really great range of options. I must say that at home with my parents always comes last in this sort of little question here. And I'm so glad that you are happy to be here as well. Fantastic. Okay, next one. Next question. Let's see how we go on this one. Let's clear this. Now this is Fred, and I'm going to ask you a very difficult question about Fred that I want you to answer for me. What is Fred? Is he a dog, a cat, a tortoise, a gerbil, a horse, or I have no idea? Excellent. Very good. Good. Very good. And that's why you're going to do vet school, so that you know that he's not a tortoise. I know you're joking, but excellent. All right. Next question about Fred. Fred loves best people, cats, food, mud, all of the above. Yeah, all of the above. But especially food, because he's a Labrador. Very good. Socks, yes, that's very true. The number of times that socks have had to be retrieved from Labradors that love chewing smelly socks, and other less salubrious items of clothing as well. Okay, fantastic. Good. All right, let's move on. Now, what I want you to do is I want you to close your eyes, and I want you to imagine that you are not just a veterinary student, but you are now a veterinarian. So you have completed all of your coursework, the didactic coursework. You have graduated, and you've gone through the wonderful RVC graduation ceremony, and you're now on your way to be a professional veterinarian. And then you are now a vet. And what that means is that you are going to have to help the animals that are under your care, interact with the clients, and really start to use all of those skills and learning that you developed over the 6, 5, or 4 years of the course, whichever way you came into the course. So I've shown you some of these pictures on Monday. So we have lots of interactions between pets and their owners, between animals and their owners. Vets are doing all sorts of jobs. Now, I'm a small animal vet, and that means dogs and cats for me. So we're going to be talking about dogs and cats, but clearly if you're interested in, for example, exotics, as we talk about, you might find yourself on the anesthesia end of a lion, and just all sorts of ways that vets interact. Now, a really common presenting sign in small animal practice is vomiting. So the owner will say, my dog is vomiting. And we're going to talk about a few dogs where that may be the problem. So we might be talking about this little guy, this little guy, this little girl, and this little guy. And if an owner tells us that their dog is vomiting, there's a bunch of things it could be. Bunch of things. It could be that they've eaten something. It might be those socks that have got stuck in the stomach or stuck in the esophagus or in the intestine. It might be that there's a tumor inside or they've twisted their intestine. It might be that their esophagus that is all inflamed or blocked. It might be that they've got gastroenteritis. They've got a really inflamed gastrointestinal tract, and that might be because they've eaten something weird. They've got an infection, they've got parasites, they've got toxins, there are drugs, allergies, all sorts of reasons. It might be that there's a problem in other organs like the liver, the pancreas might be inflamed. And it might be that some organ has failed, so they may have kidney failure, they may have liver failure, they may have adrenal failure. So there's a lot of stuff. There's a lot of reasons that can cause this very common clinical sign, and they're all very different, and some of them are life-threatening, some of them aren't life-threatening, some of them can be treated symptomatically, some of them can't be. And so trying to sort out what this dog that has, or cat that has presented to you that's vomiting, and trying to sort out whether it's going to be something that's really life-threatening that you need to do something about quickly, if it's something that's very chronic that needs to have lots of tests. It's quite the dilemma. So one of the things we start off with, of course, is the consultation, because we've got to find out information about this patient and find that out from the client, because the patient can't tell us. We have to take a history. If we were a doctor, we'd be taking it from the patient, unless, of course, we're a pediatrician. We would be taking it from the parents. So we're taking it from the parents, if you like, of the dog. And this is where it starts. This is what's called the consultation. And this is where we will take a history, find out more about what the problem is, how long it's been going on for. This is the time when we will do a physical examination. We'll examine the dog or cat and find out if there's any abnormalities that we can detect. In this time, we're also going to be making decisions about the appropriate tests that this dog needs or treatments. And really importantly, we've got to explain the reasoning behind our decisions to the owner, because ultimately they have to agree with them. They're paying the bill, unless they're in a charity practice. And so we have to have what we call a sort of shared ownership of the decisions that are going to be made about this pet. And then we're going to have to decide, does this animal need medicine? Does it need tests? Does it need surgery? Does it need all of these? So it's a very complex interaction that's going to occur. And you might think, well, there's lots going on there, I'll have lots of time to do it. But in fact, certainly in the UK, the time that you have for a consultation in a standard veterinary practice, it ranges from 10 to 15, if you're really lucky, 20 minutes. And that's a lot to get through in that time. So one of the things that you'll learn when you do the veterinary course is that we talk to you about how to structure a consultation, how to use communication skills to get the most information from the client about the pet or the animal, whatever that you're discussing. The very first thing you need to do is you need to prepare yourself. You need to be prepared for this interaction, because what you're going to need to do is to create rapport with both the client and the pet very quickly. Because if there's no rapport, if there's no connection between that owner and you, or that pet and you, then it's going to be much more difficult to get the owners to agree to the plans that you want to make. We ask various sorts of questions, and open questions are those where there's not a yes/no answer. They're the ones that are exploratory questions, asking about the pet so that the owner will volunteer for us information that's really important. And one of the things we talk about is the golden 3 minutes in the consultation. It might seem like a long time in a 10-minute consultation, and it can be, but basically the idea is that if you let the owner speak for the first 3 minutes uninterrupted, listening very carefully to them, you will probably find out most of what you want to know. This will seem a funny one, the next one, obvious examination of the pet. One of the things that we sort of take for granted is that we know why we're examining a pet. We know why we're feeling the abdomen. We know why we're picking up the stethoscope and listening to the chest. But the owner may not do that. So what the owner wants to see is, one of the things they want is they want to know that they're getting good value for their money. They want to see you doing something. And so what we say all the time is, make sure that the owner understands what you're doing. I'm now about to feel his tummy to see if there's any pain in there. I'm now about to listen to his lungs to see if there's any problem there. I'm now about to look into his mouth to see if there's a problem in the mouth. It's really important that during the consultation, and when we come to the point of where decisions need to be made, that we actually make recommendations. We don't say, well, this is what I've found, what do you want to do? It's actually important that we make recommendations, that we help and guide the owner, but obviously not boss them. It's not a paternalistic system that it used to be, where the doctor knew best and they just said, you do this. We have to come to a shared decision-making place, but we also need to help the owners with that. So I would recommend that we do some blood tests now. The owner may say, well, no, I can't afford them. Okay, well, I would recommend that we cut down the test. So it's about making recommendations. Then, as we've taken the history, one of the things that's really important is that we're checking on the way through to make sure the owner is understanding what we're asking them, that we're understanding what they're saying to us, and that we signpost what it is that we're doing. As I said, we signpost about the physical examination, but we also signpost in the history. So things like, I'm now going to ask you some questions about past medical problems. Is that okay? Or I'm now going to ask you some questions about how long the problem has gone on for. And then at the end of the consultation, we're going to need to say goodbye. And it might be that the animal is going to have some specific treatment and go home with the owner, or it might be that we're deciding to admit this animal to hospital. But whatever it is, we need to be sure that the owner is comfortable with the decisions that have been made and they're clear about what has been said. So how do we create rapport? And for some people, this comes incredibly naturally. And they'll say, why do I need to be taught this? Why do I need to write down in an examination, for example, how I would create rapport? But we're all very different. And it's really important to, even if we do create rapport naturally and very easily, it's important to recognize what it is that we're doing that creates that rapport. So one of the really important things is, right from the beginning, we bring the pet into the greeting. We say something about him. Isn't Ginger handsome, brave, lovely, fluffy, gorgeous? Even if Ginger is the ugliest cat you have ever seen in your entire life, and he looks like he's about to take your face off, and he's a very grumpy cat, we still say, try and say something nice. So many clients will say, well, that vet seemed okay, but they didn't really take any notice of my pet. It's really important to do this right from the off. And really important to use names of both the pet and the owner. So Mrs. Smith, lovely to see you here with Fred, using both of them and greeting. What this means is that you're greeting and you're talking to them both. You don't just say, hello, Mrs. Smith, come into the room, and completely ignore the pet. Establishing the agenda, and this is establishing how we're going to get the information from the client. So asking open questions. So these are things where there's not a yes/no answer. So for example, what can we do for Fluffy today? Now, what I've learned is that one of the worst things you can say is, so what's the problem with Fluffy? Because if you ask that, there are some real smarty clients who'll say, well, that's what I'm here for you to tell me what the problem is. And it doesn't really get you off in a very good mood when they do that. It's really important you establish what the owner's priorities are, because they may be particularly worried about something. They might be particularly worried about loss of hair on the back of the coat, but you can immediately see that this dog is looking very weak and very unwell and very thin. But you need to recognize what their worries are and also what their priorities are as well. You need to let them tell you the whole story. Don't assume that you know. Assumption can lead you down some very dark and black paths. And this is what's called actively listening. And this, I think, the next slide I'm going to show you is really important in every aspect of life, And what it's called is the levels of listening, the listening ladder. And I will admit that when I was first introduced to this concept, frighteningly, not all that long ago, I understood that, the first part, let me just find my spotlight. So the first bit is not listening. Okay, so someone's talking and you're just simply not listening. So you can probably reflect on a time when, I don't know, a parent's flapping their gums, or a brother or a sister, and you're just not listening to people. What's really common is this one. Think how many times you do this, that you're listening, but actually what you're doing is you're waiting to speak. While you're listening, you're thinking in your head, I'm going to say this next, I'm going to say this next. And it's actually related very much to this one, listening to disagree. So I'm listening to someone saying something and I don't agree with what they're saying. So what I'm doing is I'm just waiting for them to draw breath, and I'm going to then tell them why I disagree with them. This one here is listening to understand. So this is probably the first active listening step. So this is listening to understand what it is that someone is saying to you, the client, your friend, your parents, whatever. What is it that they are saying to you? And active listening, really avoiding this bit, the listening to speak or listening to disagree, can be really hard, And in the course, you'll do some sort of exercises where you engage with active listening by a variety of strategies. And then this is the one, the listening to help the client understand, that took me quite a long time to get my head around. But what it is where you're listening to what they're saying, and you're listening for the clues or the pointers that will help you understand why they may not want to do tests, or why they're so upset about their pet at the moment, or why they are opting for a less optimal treatment. It's listening to get those clues. And if you think about it in relationships with your friends or family, and if someone's really upset about something, clearly often you're listening to understand. But if you're listening to help the person understand, that's the next level of it. And these things happen, we have to use all of these skills in the consultation. So I mentioned open questions. So what's the difference? So open questions are those that start with something like, what can I do for Fluffy today? Or when did this start? Or where do you think he's painful? Or how do you think he got here? Why do you think this might be happening? Whereas closed questions tend to be answered with a yes or a no. So have you wormed Tom recently? Or are you up to date on wormers? Or did you try that new food? Or has he had all his tablets? And they can be helpful for establishing facts, but they can also restrict the information gathering when trying to establish the pet's problems. So it's a mixture of both that we use to make sure that we have taken as complete a history as possible. And the reason why this is so important is because the vast majority of clues to the patient's problems lie in the history. In human medicine, it's estimated that 80% of the sort of enabling factors that lead to a successful diagnosis are in the history. It's probably a bit less in veterinary medicine, where we can't ask the patient directly. In some, depending on the type of animal, depending on the type of practice, a lot of the history taking may relate to husbandry. So for example, if you're dealing with exotic animals, rabbits and bunnies and lizards and birds and all of those sort of things, because so many of the problems that those animals experience relate to their husbandry, then the history taking is very much around that. Similarly, in production animals, it's incredibly important to gather details about husbandry. But even in small animals, so I was talking to a veterinarian who was working somewhere else in the world, and they were telling me how they had a dog that came in that was losing weight. It seemed to be really hungry. It had lost loads and loads of weight. And they asked about the diet, and they said, yes, it's a on a very good commercial diet, a good quality diet. But when the vet asked to see the diet, what he realized was that the diet was a fake diet. It was just sawdust that had some meat juices through it. So this poor dog had been eating this sawdust rather than being food that had been packaged into what looked like a genuine package of dog food. So using questions to establish the genuine. So what we tend to do is start with sequential open questions to get a broader picture of what's going on, listening really actively to what the client is telling us, and showing that we're listening actively. So nodding, for example, using words to indicate that you're listening, such as, yes, I see, repeating phrases that the client might have said, and following up with questions. And this applies again to when you're listening to a friend telling you about something or an experience or a problem that they've got. These sort of strategies really help show that friend that you are listening actively to them, that you're not just listening with half an ear while you're looking at your phone or doing something like that. And that's all great, but what's the subtext of the consultation? What are we doing? Well, what we're doing is that we are trying to identify the problem or the problems the pet has. And this may be more than the client realizes. They may have recognized one thing, but actually there are more things going on. You're also collecting information about the problems that will help you make decisions about the appropriate tests and treatments that you're going to recommend. And it really is a puzzle. And that's what's so great about clinical medicine, is that it's a puzzle. I'm a medicine person, so I love medical problems. Surgeons love surgical problems. Radiologists love the problem of assessing a radiograph and what it looks like, or ultrasound. We're always solving problems. And the structure of problem solving that we teach at the Royal Veterinary College is pretty much based on a very standard, if you like, problem solving structure that applies to anything. And this lower picture that I've got here, that I've ripped off the net from somewhere, is actually what we're doing: defining the problem, assessing the problem, planning what we're going to do about managing the problem, implementing that plan, and then very importantly, communicating that plan to our client. So when we think about the enabling factors, I mentioned that history was so important. So physical examination, though, is absolutely crucial, especially as our patients can't talk. And as we know, there are 5 senses. There's sight, there's hearing, there's taste, there's touch, there's smell. And we use all of those, except, you'll be pleased to know, taste. We don't have to taste anything. But sight's obviously really important. Hearing's important, touch and smell, because there are some disorders, for example, that we can actually smell the problem. So we can smell if you've got the right genes. You can smell whether a patient has diabetic ketoacidosis. We can smell kidney failure. We can smell a really rotten infection. And so we use all of these different senses to gather as much information as we can about our patient from the history and the physical examination. Right, so let's go back to our dog. Our dog is vomiting. And so we've got our puppy, we've got our Cairn Terrier, we've got our Dalmatian, and we've got our crossbred Angus. The first thing we want to do is we want to think about the structure, and we apply this structure to as many clinical problems as we can. And what it is that the first thing we want to do is we want to define the problem. We want to make sure we know what the problem is that we're dealing with. And I'll explain that in just a little bit. And then we want to define the body system that's involved. We'll talk about that. And then we often, not always, want to define the location within the body system. And then we want to define the lesion, what we call the differential list. What's the actual pathology? And this is a statement that works in whatever problem, whether it's a veterinary problem, a human problem. So let's just say if you have your phone rings and you pick it up and it's your friend, and your friend's saying, oh, I don't know what to do. I don't know what to do. I'm really, really upset. I don't know what to do. What's the first thing that you're going to ask your friend? What are you going to ask your friend who's going, write it on the board? What are you going to ask your friend who's going, I don't know what to do. I don't know what to do. Oh, I don't know. You've got to help me. I don't know what to do. What are you going to do? What are you going to say? What are you going to say to them? Hopefully not exactly what happened, what's wrong, exactly, yep, what's wrong. You're going to be saying, you're going to be wanting to define the problem. You can't help them solve it, if that's what they want, without having defined the problem. And this is really important. And the reason why, you might have noticed that I said my dog is vomiting, but I put vomiting in inverted commas, is because what appears to an owner as vomiting can actually be something very different. So yes, they may be vomiting, they may be bringing up intestinal or gastric contents from their gastrointestinal tract, so that's vomiting. But they might actually be regurgitating, and what regurgitation is when they're just bringing it up from the esophagus or occasionally the nasopharynx, so just the esophagus rather than before it even reaches the stomach. Or they may be gagging because in vomiting, we often see that dry retch that happens before the vomiting happens, and people see that sometimes as gagging, but the animal may be actually gagging, but the owner thinks that it's about to vomit. Sometimes the animal may actually be coughing and then bringing up a little bit of expectorant after they've coughed, and the owner then describes it as coughing. And then what we're seeing more frequently now is what we call reflux. So this is not active vomiting, but it's reflux of gastric contents. And we see this with increasing frequency in the breeds that are very brachycephalic, very flat-faced. Unfortunately, very trendy breeds because people want to see that sort of flat face as like a human, but these dogs have real problems because of the structure of their face, and one of them is that they're very prone to reflux, which can look like vomiting as well. Now, true vomiting has a number of stages, and the reason why it's important to know what they are, so this is the physiology of vomiting, is that we can see some of these stages in our patient, or the owner can see them and report them to us, and that helps us confirm that our patient is indeed vomiting. So what almost always precedes vomiting is nausea, that feeling of nauseous. And I'm pretty sure everyone, all of us have had that experience for various reasons. So we have that horrible nauseous feeling, your face might go a little bit crackly. In animals, what we see is that we might see, they can't tell us that they're nauseous, of course, but they will often salivate, and that increased salivation can be shown by licking lips, by drooling, by repeated swallowing. That will then progress to retching. So this is what's sort of also known as the dry heaves. So it's a vomiting movement, but nothing is expelled. And then it moves on to vomiting itself. And then a number of things happen in vomiting. The body's very clever. So to prevent aspiration of what's about to come up from the stomach, through the esophagus and out the mouth, to prevent that being aspirated accidentally into the lungs, the body's got a protective mechanism. So the epiglottis closes and the soft palate presses up against the nasopharynx. So it's blocking off that trachea, blocking off the larynx and trachea to try to stop aspiration of contents. The abdominal muscles contract because abdominal muscles are needed for that force of vomiting, and owners may often see this. The diaphragm contracts, they may not see that. In fact, they won't see that, but they will, or they may see the abdominal muscles contracting. So how does this contrast with regurgitation? So regurgitation, so what I should say is that therefore vomiting is a very coordinated and very neurologically coordinated activity, whereas regurgitation is passive. There's no coordinated movements. What's happening is that the material that is in the esophagus that hasn't gone down into the stomach because of the pathology that's in the esophagus, the food's just being sit there and it comes up, but there's no coordinated movement. They'll often gag because of food caught at the back of their throat, because the food just sort of kind of comes up and then sits there. It's often induced or exacerbated by alterations in food consistency and exercise, and it's certainly helped by gravity. So when the neck is held down and extended, they're more likely to regurgitate. And conversely, if we're managing a patient that has an esophageal problem that causes regurgitation, we will manage them by feeding them with their head up so that gravity can facilitate the movement of food down to the stomach. And these animals have no protection against aspiration. The epiglottis doesn't close, the soft palate doesn't push up against the nasopharynx. And so what happens is that these dogs and cats, but it's more common in dogs, are really at risk of what we call aspiration pneumonia. So they inhale stomach contents into their lungs and then get a secondary problem, which can be life-threatening, of pneumonia. So what are the clues? Because that's the very first thing we want to establish. The very first thing when an owner says to me, is my dog's vomiting? Now, of course, I also reflux a little harder because it can look like vomiting, and often it's treated very similarly. The gagging, coughing thing, you can usually sort out with a decent history. But the vomiting and regurgitation, sorry, the gagging, coughing thing is quite, you know, you ask questions around the sort of whether they're coughing and things like that. But the differentiation between vomiting and regurgitation can sometimes be quite challenging. So we're going to be looking for clues. So we're going to be looking for behavior. Is this animal drooling, for example? Are they food averse? Do they look like they're nauseous? Do they have abdominal contractions? A really important thing is their bile in what's being brought up, because if there's bile in what's being brought up, we know it has to have come from the intestine. Now, if it's absent, it doesn't mean this animal isn't vomiting, because we can have patients who will vomit gastric contents from their stomach, where there's been no mix of intestinal contents and there's no bile. But if there is bile, if there's yellow color material, then bingo, you can go, great, I've got vomiting, that's terrific. Now, the acidity of the material can sometimes help, although if it's very acidic, we can conclude, therefore, that it has come from the stomach, the gastric acid. But unfortunately, if it's not acidic, that doesn't mean it's regurgitation, because we may have non-acidic gastric contents. Sometimes the appearance of the food can help us. So if it's completely sort of non-digested, does that mean it's more likely to be regurgitation? And that's probably true if it happens a long time after eating, but we can have animals that vomit immediately they eat, and of course their food is not going to be digested. And cats in particular seem to like vomiting sort of tubes of food that look like it might be regurgitation, but it's actually vomiting. Here's another clue. If the stuff that's brought out is covered with mucus with a kind of sliminess, then that's telling us that it's coming from the esophagus, because that's what the esophagus does when it is damaged or inflamed. Then it coats that material with mucus. So if there's mucus there, we can conclude that the esophagus is definitely involved, and regurgitation is definitely occurring. Cough. Now, I talked about the fact that coughing can be mistaken for vomiting, but if we're happy that the animal's primary problem isn't a cough, but very often I always get really worried if an owner says to me, oh, he's vomiting, and at the same time he developed a cough, because those are the animals that I'm worried about have regurgitation, and they've now aspirated the contents into their lungs. Sometimes you need to observe. You just can't tell. Either the owner hasn't observed enough, or they're telling you confusing signs, and so you need to observe. Now, what's really helpful is obviously you can ask the owner to film it on their camera, on their phone, or you might admit the animal to hospital to observe what they do when they eat. But sometimes, and the other thing to remember is sometimes both can be happening. You can have animals that are both vomiting and regurgitating, and that particularly happens if an animal's had really serious vomiting, particularly of acidic gastric contents. They've really damaged the esophagus as that's come out of the mouth, and now they've got a secondary esophageal problem because of the inflammation that's there in the esophagus. So why is it so important to define the problem? One reason is that the investigations are totally different. The causes of vomiting versus regurgitation are totally different. The management of vomiting versus regurgitation is totally different. For example, if the patient is vomiting, very often this can be treated symptomatically. Very often, particularly in dogs, it will be because the dog ate something disgusting, they've got an upset tummy, it's going to settle without too much drama. And if it does need to be investigated, there are a variety of tests, diagnostic procedures that can be useful. There might be blood tests that would be useful, or x-rays and an ultrasound, or endoscopy, which is when we put a camera down into the stomach and intestine, or it might even be that this animal needs to go to abdominal surgery. But if the patient's regurgitating, then it rarely will respond to just what we call symptomatic treatment, so just resting and giving bland diet. If it's persistent, it's usually a bad disease. And to investigate, we need to image the esophagus. We need to look at the esophagus. First of all, by radiographs, sometimes by endoscopy. So here's a radiograph. This is a radiograph of a dog's chest. So this here is the heart that I'm showing you. Here is its ventrum, the lower part of it. Here's its front legs, its head's up this way. Here's its spinal bones, and these white things are its ribs. And then what we can see here is this white thing. So all this black stuff is lungs. And what we can see here is this white thing. And we can also see that this looks like a tube, doesn't it? And that's the esophagus, and we shouldn't be able to see that in a normal animal. And the reason why we can see it in this dog is because this silly dog has swallowed something that's got stuck in the esophagus. So that's what we're seeing here. Things like a corn cob is common, although they tend to then go to the intestine. A really bad one is lamb chop bones that then grab onto the esophagus. But we need to image the esophagus when we're diagnosing esophageal disease. Blood tests and abdominal surgery are not very good. Some are a waste of money, and some, like abdominal surgery, are downright dangerous. And you might say to me, well, of course, no one's going to go and enter the abdomen in a dog that's regurgitating. But I can tell you that in my long time as being a veterinarian, the number of times I've seen cases as what we call a second opinion or a referral, where the owner has spent a large amount of money because the vet has investigated the vomiting problem in their dog, and it has sometimes included what we call exploratory surgery to look at the intestine, when in fact what this animal was doing was regurgitating. And that's really dangerous for that patient. So now I'm going to ask you some questions. So get your pens at the ready so that you can mark on the screen. This is Norman. Norman's history was that he's a 2-year-old male Cairn Terrier. He had a history, the owner said, of repeated vomiting over the past week. The vomiting was projectile. In other words, it really shot out of his mouth, really quite a bit of pressure behind it. It was usually related to eating. So when he ate, within about 10-15 minutes, he vomited. The vomit contained bile. It looked yellowy. The owner said it was yellow. He was eating really well until the last day or so. He seems to have normal feces, and the owner really doesn't know whether he's drinking more or less. They've got lots of other dogs in the house. So tell me, is Norman most likely to be vomiting, regurgitating, or I'm not sure yet? Very good. Very good. And what was the real clue? See how you're writing, how good your writing is. What was the real clue that he was vomiting? The bile, absolutely. Yeah, the fact that the bile was there. But other clues might be, if it was a very observant owner, it might be that they'd seen abdominal contractions. Now, here's the thing. You can try this at home. If an animal vomits, they have abdominal contractions. When they regurgitate, they can look sometimes like they'll have an effort there, but the effort comes from the shoulders. It comes from, so if you practice now using your abdomen and pretending to vomit, blah, blah, blah. So pretend to vomit, and you'll notice that it's your abdomen that's involved. Whereas if you're regurgitating, if you thought there was something stuck in your throat, you'd be going, ah, 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 and trying to get something up from your throat, and that's using your shoulders. So that's something that to ask the owners specifically. Great work, well done. Right, this is Angus. Angus's history is that he's a 4-year-old crossbred dog. He has an acute onset of bringing up food for about a week. The owner said that he'd been vomiting. He was still very bright and happy. He wanted to eat. He was bringing up undigested food or water about 10 minutes after eating or drinking. There hadn't been any bile observed, and there was mucus seen on the material brought up. There didn't seem to be any abdominal effort that the owner had noticed, but what the owner had noticed was that they had gagged after bringing up food. Now, all of this information that's on this slide, some of it might be volunteered by the owner, but much of it you would probably need to get from them, asking them, what did the vomitus look like? What the stuff that he brought up? Did you see any mucus on it? What did he look like? Did you see his abdomen moving? What does he do after bringing it? So it's really important to recognize that a very good history like this is only going to happen in most instances if you ask the right questions. So, Angus, is he vomiting, regurgitating, or I'm not sure yet? Excellent. Well done. Perfect. Perfect. Great. Now, if there hadn't been that clue of the mucus, because it's not always there, and if the owner hadn't been particularly sort of observant and there was no abdominal effort, it's possible he could have been vomiting, but those little clues were telling you he was regurgitating, and you got those clues because you would have taken this really, really good history and therefore found that out. Fantastic, great work, well done. Okay, so let's now say you are happy that your patient is vomiting. You've done the first step, you've defined the problem. You are happy that the patient is vomiting. So now you've got to take to the next step. And the next step is to think about what system is involved. What does this mean? If we have an animal that's vomiting, they can be vomiting because they have what we call primary GI disease, a problem in their gut, or they can have what we call secondary GI disease, which is a problem outside of the gut. And if we look at this diagram, vomiting can only occur when there's a vomiting center. Now, it's not a center per se, it's a collection of neurons in the brain that coordinates that very complex neurological coordination that's needed for vomiting. Dogs and cats have got a vomiting center. Animals that don't vomit, like horses, although they've got some of the neurons, they could vomit, but they don't connect up. And what you can see here is that if you need a vomiting center to control vomiting, that's going to have input from a variety of places. And yes, it will have input from the gut, but it also has input from abdominal organs. It also has input from toxins that the animal might take, and they might go directly to the brain center in the medulla, the vomiting center, or they might come via what's called the chemoreceptor trigger zone, which is the part of the brain that doesn't have a blood-brain barrier, or it might come via the vestibular system, the system that's about balance. So if the patient's got motion sickness or an ear infection, or it might come from up in the higher CNS. So fear, pain, really horrible smells can cause vomiting. So this tells you immediately we can have primary gut disease, or we can have all sorts of other things that don't involve the gut directly. So defining the system, primary gastrointestinal tract, anywhere from the stomach to the anus, although, to be honest, an anal problem wouldn't cause vomiting, but a rectal problem can. Secondary gastrointestinal disease is where we have accessory digestive organs involved, like the pancreas, where we have salt imbalances like sodium, potassium, and calcium, where we have toxins that occur from kidney disease, liver disease, pancreatic failure, infections, ingested toxins, and occasionally when we have brain disease. And just like we look for clues to decide whether our patient is vomiting or regurgitating, we also look for clues to see whether our patient's got primary or secondary GI disease. Now, we can look for these clues. We might not find them. We might in the history go, I have no idea whether this animal's got primary or secondary GI disease. But there are some clues that can help us. What are they? So in primary gastrointestinal disease, vomiting will often, but not always, relate in time to eating. So there may be a set time after the animal eats that they vomit. It doesn't always happen that way, but if it does happen, it's giving you a strong clue this animal's got primary GI disease or a problem called pancreatitis, which behaves like a primary GI disease. The animal can be completely normal. They can be as happy as a clam, what I call the happy chuckers. Or they might be really unwell, and they might be really unwell because of whatever is causing the vomiting or the secondary effects of prolonged vomiting, because prolonged vomiting can really make them metabolically unwell. And so I will strongly suspect primary gastrointestinal disease if the vomiting, for example, is associated with significant diarrhea, if the patient is clinically and historically normal in all other respects, and interestingly, if the onset of vomiting significantly preceded any development of signs of illness, such as depression and or a loss of appetite. So if I've seen a patient that has been vomiting, the owner says it's been vomiting for about a week, but it really only became unwell and sort of stopped eating and looked really depressed about a day ago. That really rings a bell to me that this patient is likely to have primary gut disease. And as I said, if the vomiting is consistently related in time to eating, that will give me a strong clue I'm dealing with primary GI disease or pancreatitis, but that doesn't necessarily have to happen in primary GI disease. What about secondary GI disease? Now, when these patients are vomiting because of secondary GI disease, it is usually because there is toxins interacting with the brain, there's changes in the sort of body balance of electrolytes, and these animals are usually unwell. They're not what we call happy chuckers. So I would strongly suspect secondary GI disease if the vomiting occurred well after the development of signs of illness such as depression or loss of appetite. So if I had a patient where the owner said, oh, he really hasn't been eating very well for the last 2 weeks, he's been getting more and more depressed, and yesterday he vomited, then in most cases, not always, but in most cases, this patient is going to turn out to have a secondary gastrointestinal problem, a problem with the kidney or the liver or the adrenal glands or the pancreas, but something like that. And then I particularly suspect it if I've got some other clinical sign that tells me there's something wrong with another organ. So for example, if I had a patient who was jaundiced, had yellow gums or eyes, if they had increased drinking and urinating, which is called polydipsia and polyuria, something that's telling me there's something else going on outside of the gut. As I said, these patients are usually metabolically ill. So why does it matter? So why should we have a systematic approach? Just as I said for the systematic approach to vomiting, to the problem, the diagnostic approach and direction can be completely different, and the diagnostic tests can be completely different. So diagnostic tests might include bloods, doing urine, imaging, and if we look at investigating secondary GI disease, so this is diseases involving organs outside of the gut, then blood tests are really useful. Looking at the urine's really useful. We might image the abdomen with radiology. Very useful is ultrasound examination. And sometimes we have to do exploratory surgery to look and see what the liver looks like, what the pancreas looks like, what the kidney looks like. So all of those are legitimate and helpful diagnostic tests that we can do. But if we're investigating primary GI disease, essentially what we want to do is that we want to image the gastrointestinal tract. It's a bit like regurgitation. In regurgitation, we want to image the esophagus. When we've got primary GI disease, we want to image the gastrointestinal tract. Here we've got a radiograph, and this is the stomach in this animal that's full of what we call radio-opaque material, probably stones that this silly animal has eaten. We use ultrasound, so this is an ultrasound of the intestine looking at very thickened intestinal walls. We do endoscopy, so this is where we put this sophisticated scope down through the mouth into the stomach, into the intestine, looking at the lining of the stomach or the intestine, whether there's foreign body there, whether there's ulceration, whether there's a tumour. And sometimes we do need to do exploratory surgery. Now, this is actually the wrong picture to show, because well, no, actually for this one, it's the right one. So here we have an intestine, and we might need to do surgery to investigate the intestine, to take out a piece of the intestine, to remove the foreign body, whatever. So those are the sort of things we need to do to investigate primary GI disease. We need to image that gastrointestinal tract. And the reality, though, is that the other things that are really useful for secondary GI disease, which is blood tests, urinalysis, for example, they may give us information about the clinical status of this patient, but rarely tell us what the cause of the vomiting is. The cause, so defining the lesion, comes from the imaging. And so if we don't define the problem or system correctly, it can lead to wasted time, it can lead to wasted money, it can potentially endanger the patient by delaying or an incorrect diagnosis, and it can impair the vet-client relationship and trust. Clients do not like it when they really don't like it when you tell them that actually all of the money they've just spent investigating their dog, which they thought was vomiting, was all completely wasted because actually it was regurgitating. And what we need to do now is look at the esophagus, not at the intestinal tract. So to finish off, let's review and see how you go putting this all together. So here we've got George, and remember he's got, so we saw a picture of him before. He's a 1-year-old beagle, acute onset of bringing up his food yesterday. He's still bright and happy. He still wants to eat. He brings up food or water with bile about 15 minutes after eating or drinking. He had some diarrhea this morning. On physical examination, he's very bright. His mucous membranes are pink and very moist due to increased salivation. He's got no abdominal pain that can be detected. All his vital signs, his temperature, his heart rate, his respiratory rate are normal. So George is most likely to be vomiting, regurgitating, or I'm not sure yet. Absolutely. And what were the clues that were telling you that he was vomiting? The bile, yep. And what else? What else on that physical exam? Yeah, the signs of nausea, wasn't it? The salivation, absolutely. Yep, the salivation. So we've got a very strong steer here that George is most likely to be vomiting. Well done, that's fantastic. Now, the next question is he most likely to have primary GI disease, secondary, or I'm not sure? Fantastic. And why? Why do you think that? What is it that's telling you? He's got the diarrhea, yep. You can get diarrhea with secondary GI disease, but yep. It preceded other symptoms. He's still very bright and alert, yep, yep. Seems normal otherwise, yeah, absolutely. Everything about George is saying he's got primary GI disease. And now we've got to think about, well, what could it be? And so now we start to think about the lesion. So he's a beagle, they'll eat anything. He's a pretty young dog. So we're worried that he's eaten something silly. And if he's eaten something silly, like just the garbage or something like that, then it's nothing too much to worry about. But what would be the thing that he could eat that would be kind of life-threatening for him? And it sort of came up, what a puppies like to eat. And we're going to have the socks again, aren't we? Socks and rocks. Absolutely. Well done. Socks and rocks. A friend of mine who's a surgeon gives a lecture called Smelly Knickers and Other Things Found in Dogs' Gastrointestinal Tracts. Corn cobs. They love corn cobs. If any of you are in Australia, I don't know about elsewhere at McDonald's, but McDonald's does really nice corn cobs that are very small, and dogs love them because they're covered in butter and they're perfectly designed to plug the duodenum, the intestinal tract. Fantastic. In George's case, he'd just eaten something silly. The diarrhea kind of tells you that really. What you'd be worried about in his case if he didn't have any feces, that might make you worry about the socks and rocks option. Okay, well done. Okay, here's Geraldine. So Geraldine is a female neutered Dalmatian. She's 3 years old. She's bringing up bile stain material for 3 days that's been unrelated to eating. She's been drinking and urinating excessively for several weeks. She's had a reduced appetite for at least 10 days. Is she vomiting, regurgitating, or you're not sure yet? Yep, perfect. And what's telling you that she's vomiting? Again, the bile. The bile is the kicker. You can't bring up bile without having brought up intestinal contents. And you can't bring up intestinal contents without vomiting. It doesn't happen in regurgitation. It doesn't happen in regurgitation. Now, you can definitely vomit without bringing up bile. So particularly if you have a stomach problem, and particularly if it's what we call an obstructive stomach problem. So if, for example, a dog had eaten a sock is a perfect thing that will sit in the stomach, block the outlet. They'll vomit, but they'll only vomit gastric contents. They won't vomit intestinal contents, so they don't see the bile. So, well done, fantastic. Now, the next question, you know what's coming, is on physical exam, she had increased body temperature, yellow gums, she was dehydrated, depressed. Primary, secondary, I'm not sure yet. Absolutely. Now, if you say, I'm not sure yet, that's okay, because there is some sort of weird things that could happen, particularly with the jaundice. But the fact she's been drinking and urinating a lot over the past several weeks is a real flag. Now, maybe that's due to another disease. Maybe she's got two diseases going on, but we won't get too complicated here. Most of the time. Now, the depression is important, but what's really important is that the depression happened before she started to vomit. So if she'd been vomiting for a week, but she presented very depressed and that depression had only been occurring over the last 24 hours, then that would be more likely to be primary GI disease. Fantastic. You have done a wonderful, wonderful job. A really great job. I can tell you, I do this lecture sometimes with vets and they get it more wrong than you do quite times. So now I'm going to open this up to questions. I haven't been looking at the chat, but I will look at it now. So if you want to answer your questions, I think we've got a little bit of time for questions. Do we, Rich? Do we,
yes,
Chris?
we do, Jill. We
okay,
do. We haven't got too long. We've just got
okay. Can you moderate the questions for me?
Absolutely. So I've got a good question here from Keisha, which has said, what was that point about having the right genes enabling you to smell diabetes? Brackets I've never heard.
Oh, yeah. So it's really interesting. It's a bit like how some people can smell nail polish and others can't. It's an ability to smell ketones. And some people have it, like I can smell them, but other people can't. Sometimes the way to test it is just, if someone's not eaten for a day, they will often become temporarily ketotic. And if you can smell that, you can smell them. You probably won't necessarily find out until you're in the clinic. It's a really useful gene to have. It's quite common, but there are people who can't smell it.
Is that the same with asparagus as well?
Yeah, so apparently, my brother told me this yesterday. There's 4 variations of being able to smell asparagus of your own wheat, but not of others, not being able to smell it. Yeah, so yeah, it's a similar thing. Yep.
Amazing. Got a great question here from Yanashine, which says, how do you gather information from an owner who isn't communicating well? Any tips?
Yeah, that's a really great question. A really great question. And that's hard because there might be various reasons why they're not communicating well. It might be that they, if there's an interpersonal issue going on, you know, they're angry or they're blocking, you've just got to try and work on that. But sometimes it might be a language difficulty. Sometimes it might be that they just don't know. So for example, it may be that someone who doesn't really look after the animal has brought it in, or it might be, if you work in a practice where there are very rich clients, it can be, I used to have a client who was the wife of the ex-Prime Minister of Australia, and she had a housekeeper who was a lovely woman who always brought the dog in, but didn't have as much knowledge about the dog as the client did. You just have to work on it, and part of it is actually defining the problem. What is the reason why this client isn't being communicative? Is it that there's something Is there a block between the two of you? Is it that they don't know? Is it they can't express it? It can be so frustrating because you can have two people in a consult. Let's say you've got a husband and wife, and you'll say, so, you know, how is Fluffy's appetite? And one of them will say it's great, and the other one will say, no, he's not eating very well. So you can have that as well. I'm not saying it's easy. I'm not saying it's easy. One of the things our students always complain about is that when they're in our hospitals, they have to go out to the client and take the history, and then we go out and chat to the client. And very often I'll go into the consultation room and I'll start to talk to the client, and the client will tell me something, and the student will say, I swear I asked them that question and they gave me a different answer. Now, whether it's the way I ask it, whether they are more prepared to tell me as the vet than the student, I don't know. But it can be a real challenge. It can be a challenge.
Fantastic. Well, Jill, I'm afraid we're going to have to end it there because we're going to have to start the next presentation, but that was absolutely fantastic once again. I'm sure the students loved it. And see the
okay, well, lovely to see you all, and I hope you enjoy the rest of your week. It's just been great talking to you. Okay.
Oh, thank you. And Jill, can you teach me how to do these annotations as well? Really...
Of course, I can. Or one of the students can. They'll be able to tell you too.
Yeah, perhaps. Okay then, Jill, thank you so much.
Okay.
Students,
lovely to see you all.
in the next presentation.
Okay. All right. Bye.